Welcome to this morning's briefing. Mergers and innovation, measuring performance in patient care. I'd like to start out this morning by thanking our sponsor, 3M, for making today's program possible. The American healthcare industry is undergoing rapid change. From mergers and acquisitions to the creation of new entities to tackle rising healthcare costs, these developments are poised to significantly influence the delivery of patient care. And there are opportunities to use mergers and acquisitions to improve the quality, accuracy, and efficiency of patient care? How can we measure the performance of healthcare innovation? And what is the role of Congress in ensuring that the consumer remains at the center of all these changes? This morning, we'll be hearing from leaders in government, Congress, patient advocates, and health economists. Before we begin, a few housekeeping notes. Please keep your phones on silent, but we do encourage you to engage in the discussion on social media. We will be recording the on-stage conversations. The video will be available for viewing after the program on thehill.com/events. You can follow us on Twitter at @TheHillEvents and comment using the hashtag #TheHillTalksHealthcare. We're going to be taking questions from the audience during this program, so please be on the lookout for members of our team with handheld mics. And finally, there's a short feedback survey on our chairs. We'd love to hear from you about our events, so please take a moment to fill out the surveys at the end of today's program. Let's dive right in. We begin with Senator Bill Cassidy. Senator Cassidy is a physician and member of the Senate Help Committee. A leader on healthcare issues, he recently put forward a white paper outlining ways in which the healthcare system can be made more affordable while improving patient outcomes. Please join me in giving a warm welcome to the senator. And joining him on stage is my colleague, Alexis Simendinger, the Hill's national political correspondent. Alexis, over to you.
How are you? Senator, it's great to see you. Thank you so much for joining us.
Thank you for having me.
Taking a break from the calmness, the comedy of the Senate. We're here to talk about, hopefully that feedback will leave us. We're here to talk about this interesting, fascinating trend, as you know, the mergers and acquisitions in healthcare. And we're going to leave plenty of time for questions for all of you who have detailed questions that you'd like to ask the senator. We're going to have time at the end. We're going to ask you to stand up and introduce yourself. And then later on, of course, we have a panel with my great colleague, Peter Sullivan. So let me start off by asking you, as somebody in government and somebody who has been in healthcare as a physician, as someone who started off with a career with nonprofit clinics in Louisiana and has seen it all, do you think the innovations that we're watching in the health industry right now are more likely to be driven by the private sector, what we want to see in healthcare for patients and for affordability, or by government?
That is a complex question. Because what we see right now in the private sector, first let's start off. What you have to have foremost is the patient, sitting around her kitchen table, unable to afford her bills. And since 2007, what she spends on health care has increased by 25%, and what she spends on everything else has decreased. So increasingly, health care is consuming her budget. If you look at some of what's happening in the private sector, it is awful for her. The consolidations of providers, where studies show that when hospitals combine, cost increased by 12%. The consolidation of insurers, where if you have only one insurer in a market, that's basically monopoly pricing, and they can raise their rates to whatever they are, and on the individual exchange, the federal subsidy just follows whatever they decide to bill, because it is a monopoly. For her sitting at her kitchen table, we actually need we need more competition. So if the private sector consolidates, that's bad. If the private sector, with directive from the government, puts in something such as price transparency, we have that in our white paper, price transparency, that's good. It allows her to get the benefit of competition where she can use her health savings account and get the better price. So there's no simple answer to what you just said. It could be awful if it's consolidation. It could be fantastic if the federal government or the state governments drive something such as price transparency, which gives her more power as opposed to just being subject to the consolidators.
Let me ask you for your analysis. What do you think, this trend is not new, but it certainly is accelerating and it's expected to continue in 2018. What prompted this trend? Is it a search for profits and competition?
The consolidation.
Yes.
Consolidation has begun at least 20 years ago. But if you will, it's mutually assured competitiveness. So as insurance companies consolidate, they have strength relative to hospitals. So hospitals consolidate, so therefore that returns the strength. And physicians attempt to consolidate, never quite as successfully, more often bought either by insurers or by hospitals. But nonetheless, they're all attempting to improve their negotiating position one with the other. Now, going back to that woman sitting at the kitchen table, surrounded by hungry children trying to make ends meet, they are making more and more money, and she is paying more and more. She is the least able to pay more and more, but she is the one who's being called to either by higher taxes or higher premiums or lower take-home pay as her employer pays more. We've got to lower the health care costs for her. Competition improves it. And again, I'll discuss that more fully in my white paper.
You're describing a sort of on the one hand, on the other hand kind of equation, the way you look at it right now. As this experimentation and this collaboration continues, how are you going to assess the value for patient needs, for transparency, which you just talked about, for affordability? How does the Senate and the Congress grapple with that question?
Hopefully we grapple. I will say that to an extent it has been lost. But you can look, since 2007, the amount the average family has put towards health care costs is well documented. It is increasing. If you look at the premiums they've increased, both in the individual, particularly in the individual, but also in the employer, but the deductible and co-pays have increased even more dramatically. So one, it's clearly documented. How do you judge success? You judge success by whether or not we begin to implement those things which give the patient the power. Again, I can be exhaustive, but we have it on our white paper on our website. But if you give the patient the power, you lower cost. For example, one thing the administration is seeking to do is to eliminate so-called gag clauses, where a pharmacy benefit manager will tell a pharmacy that you, by contract, cannot tell the patient if she would save money by paying cash, because paying cash is less than her deductible. The pharmacist is not allowed to tell the patient because of a gag clause. That is wrong. And that makes her pay more, so someone making much makes far more. I can give you other examples, but if we have price transparency so the mama can scan the barcode, if I get the CT scan for my daughter right now, it costs $2,500, but if I go Thursday at midnight, it costs $250. Baby, we're staying up Thursday. Now, she then has the power in her HSA to get the better price for her family. She needs that power. Now she does not have it.
Do you think, though, that consumer choice or consumer knowledge is enough? Is that, or is there a larger role for Congress? You started by saying hopefully that Congress will grapple.
So Congress can set up rules, but it cannot micromanage. Mm-hmm. It is terrible when it micromanages. But if it sets up rules of the road, for example, you have to provide, if a patient is paying cash, a provider must provide what the all-in cash price is for elective procedures. Think CT scans, blood tests, et cetera.
So you're supportive of that?
Totally. And that a pharmacist must publish what the cost of a medication would be so that the patient can know that price before she walks in the door. Another example. Consumer Reports had secret shoppers go out and look for 5 different generic medicines. And the price ranged from $44 to $700 for the same generic medicine. The patient wouldn't know that it was $44 here and $700 there unless they happen to knock on every door. If we give her the power of knowing the price before she walks in, and Congress can set up that rule, then the market will respond and she will pay less. That is a good thing. She must have the power, and if she has the power, then prices will come down and we must control healthcare costs.
Before we leave this, because you're a physician and you started off working with a lot of low-income patients, dental patients, healthcare patients in Louisiana. Is it your experience that all consumers have the capability of doing this, being smart consumers?
So what you're suggesting is that sometimes the healthcare system is too sophisticated for someone to gather. So you couple that with the patient-physician relationship. Statistically, if the patient has a strong relationship with the provider, then, and if they both have kind of alignment of the patient's physical and financial health, that is optimal. The patient cannot know who is the best gastroenterologist for her particular condition, but the doctor knows. And if they have a mutual interest in making sure that her physical and financial health are respected, and there's systems of care that do that, then together they augment her power, and so that whatever sophistication, knowledge base she lacks is compensated by the physicians. Again, there are systems of care that do that, and well worked out statistically and academically analyzed, and that's where we need to be going.
Let me take you to your proposal, which has stalled. This is an election year, but your proposal to try to tackle the healthcare challenges and find consensus. You were talking and proposing block granting federal dollars to the states.
No, per capita cap, which is somewhat of a different concept, but I'll cut you slack.
Okay. Would your proposal be supportive and actually complement the trend that we're seeing in mergers and acquisitions in the private sector?
So if you're talking about mergers and acquisitions on the insured, then clearly they will respond to however the payor decides to pay. And if you make it where, as the Federal Employees Health Benefit Program, Alexis, I suspect your own employer says to the insured, to the insurer, we have this many employees, they are this age, this gender, they are of this health status, based upon experience, we're going to pay you a certain amount of money per enrollee, adjusted for all those factors. That's what they do. By the way, our per capita cap did the same thing. Our per capita cap, the federal government would do to the state what states are doing with Medicaid managed care, which is that we have this many patients, this gender, this race, this whatever, and we're going to give you a risk-adjusted amount per patient. That is good. The reason why? Not only does it help control cost, but it decreases unnecessary utilization. If you pay people no matter what volume and intensity of service they provide, you spend a lot of money, but there's also going to be more complications. Once you actually have somewhat of, okay, it has to be justifiable, then not only do you conserve cost, but you also have an appropriate volume, an appropriate intensity, and the patient is better cared for. So our per cap, mergers and acquisitions, they would respond to that because they responded to it on the state level. They have responded to it in the large group health level.
Okay, let's open it up to questions. There's microphones here. If anybody has some questions, please raise your hand and the microphone will find you. Please tell us who you are and who you're with, and Senator Cassidy will respond.
Hi, my name is Nam Nguyen. I'm a cancer physician. I just want to ask you why the cost of the medication is so expensive in the US compared to Canada, for example. And it affects us directly. I have a patient, like you mentioned, who got cancer. She got radiated mucositis. I prescribed her a medication for mucositis. And the next day she came back, she said to me, "Doctor, I'm retired. That medication costs $500. So I have the choice either not eating, take the medication, okay, or take the medication and cannot buy medication. And there's no generic for that medication."
Yeah, so the question about high drug costs in general, I think will cover your question in particular. Again, our white paper has on our website, has a fair amount of sections on high drug cost. There is no single thing which is driving up healthcare cost. But on the other hand, there's lots of things on the margin that are acting towards it. So if you want to look how new drugs are marketed, there was a series of articles in the Wall Street Journal that looked how Pfizer was marketing a new cancer drug, and it's basically what the market would bear. They did market research, what would an oncologist prescribe, and when they did that, then they would then peg their price there. and it turned out to be quite expensive. So we have kind of an upside, but no restraint upon what the initial drug cost would be. If you're talking about the pharmacy benefit managers, which are asking for very high rates from the pharmaceutical manufacturer, they rebate a large amount of that back to the insurer, but in most cases right now, patients are not receiving so-called point-of-sale rebate. They're paying the gross price, not the net price. The patient in her copay, in her deductible, is not getting the advantages of the negotiated net price. So that's another reason. We could go on, but in the situation you described, both of those could be the case. And again, in our white paper, we have different solutions as how to address that. And I won't give a litany here, but please go there and look at it, and we'd love your feedback.
This gentleman right here on the aisle.
Hi, my name is Shivam Shah. I'm a medical student. Thank you very much for being here. My question was, do you think that the United States should use, on a broader level, should use yardstick competition to a greater degree?
Should use what?
Yardstick competition when trying to identify pharmaceutical prices, kind of looking abroad and seeing what other bins of countries are doing. And then maybe on a more system-wide level, use more tiered formularies for drug price, to mitigate high costs for drug patients to patients.
So we in our white paper do reference pricing, where the U.S. would look at what maybe 5 or 6 other large developed economies are spending on certain drugs. Germany, France, Great Britain, Canada, and Italy. Pick a number. Japan, Australia. And you put reference pricing. Now, there's a couple reasons for that. Pharmaceutical manufacturers will say, wait a second, we rely upon the U.S. market to get all of our profit, otherwise we cannot. Well, frankly, if you start linking ours to what they pay, maybe they would have more of an incentive to get more money from those foreign markets. Now, by the way, it doesn't have to be 1 for 1, it could be a multiple. It could be 1.6 or 1.5 or 1.1. But that would be a way to have some sort of connection with reality. You mentioned the reference pricing. Yes, we do think that would be something to be considered. And there was a second part to your question?
The tiered formulary?
Tiered formulary. Yeah, tiered formulary, going back to aligning the incentive between the patient and the doctor, it may be the doctor knows that if I give an infusion which costs more, I'm going to have fewer complications, and the patient's more likely to be compliant and less likely to come into the hospital. So that's why I'm so much into this patient-physician relationship, because sometimes a tiered formulary is great in concept, but then the patient's non-compliant and you end up with cost on the back end. Whereas if the doctor says, wait a second, we have an aligned financial incentive, I don't want to spend money because she's out and I'm out both, I want a better outcome, and global life cycle costs will be less if I give a more expensive medicine, that's when you bring the expertise to bear on this particular patient. So I'm very much kind of sure in concept you can do tiered formulary, but I much prefer that sort of thing which I just described.
Senator, we promise to let you go. Thank you so much for being with us this morning, and we'll look forward to all that you're up to the rest of this summer and into the fall.
Thank you, Alexis.
Thank you very much.
Thank you.